rays that comes from the subepithelial part of the capillary networks. So they would come up to the surface and appears as very small, normally very small vessels, like these small vessels. So beneath these green vessels are actually submucosal veins. And there are also capillary networks that can be seen on an MBI magnified image. But the areas that we are focusing on are these IPCLs. So it has been well documented that with the increasing neoplastic changes within the esophageal mucosa, you will see more and more abnormality with these IPCL. So namely dilatation, tortuosity, variable caliber changes, and non-uniformity of the morphology. So with this, you can actually determine whether you think this is a neoplastic lesion or not. So that's why it's important to look at the morphology of the IPCL. So we mentioned briefly about chromoendoscopy. So Lugol's iodine has been there for many, many years. So it has been useful in various application. Maybe a bit less in recent years because of the availability of MBI or other image enhancement method. So what you need to do is actually spray a very diluted concentration of Lugol's iodine and look for unstained areas. So unstained area meaning that the areas that will not stain up by the slightly brownish color of the Lugol's iodine. And more importantly, if you wait about 2 or 3 minutes, you'll be able to see some areas that appears pink. So this is what we call a pink color sign. So if you see pink color sign, it's even more specific for high-grade lesions. So unstained area is highly sensitive, but the specificity may not be as high. But if you see pink color area, then this lesion would be highly specific for locally advanced lesions. There has been multiple studies trying to compare different modalities. So in summary, I think MBI is one of the best. Lugol's iodine can be useful, but maybe more or less with similar accuracy with MBI. White light endoscopy, as I illustrated, has the worst in terms of accuracy to detect these early lesions. So the usage of MBI has been demonstrated in this trial more than 10 years ago, trying to compare the use of MBI versus the use of white light endoscopy in detecting the ESCC, esophageal squamous cell cancers, in patients with at high risk. So the summary of the trial basically showed that with the use of MBI, it not only improved the diagnosis of esophageal cancer, it also improved the diagnosis of head and neck cancer. So that I mentioned about the pharyngeal cancers, etc. So this is also a very important message. So that's why it's important to screen the head and neck as well, because occasionally you will see these kind of small diseases, especially in patients who have a diagnosis of another cancer in the esophagus or in the oropharynx, etc. So you need to screen these areas. So there has been meta-analysis trying to look at the incidence of a second primary lesion with the diagnosis of already esophageal cancer, and you can see at the end, the pool prevalence is almost approaching 10%. And the important message is they can appear everywhere. So in esophageal cancer, there has been many coexisting synchronous primary head and neck cancers in the hypopharynx mostly, some in the oropharynx, some even in the oral cavity, larynx, etc. And the other thing is most of these cancers, synchronous cancers, are actually low grade or low stage or early cancers. So I think this is an important message because these are easily treatable lesions. So if you can detect those, you can treat these patients at an early stage. So it's important, therefore, to always have a look in the hypopharynx, in the oropharynx, when you're assessing patients at high risk of esophageal cancers. Using narrowband imaging is equally useful. So you can see lesions like these. So there has been some development of trying to improve the visualization. This is the Valsa mouth, which is a specially designed mouthpiece trying to improve the visibility within the hypopharynx, because usually if you want to see the both piriform fossa well, you need to have a Valsalva maneuver where you blow up the hypopharyngeal area for better visualization. So this is a kind of mouthpiece that tries to mimic the use of, facilitate the use of the Valsalva maneuver for better visibility, and this has been shown in this study. So short video, you can. So this is a very short image of showing how we assess. So even if you use the MBI, you can assess the oral cavity. This patient has a cancer here. So that was diagnosed by our ENT surgeon, but you can see all the abnormal vessels and all the brownish discoloration, even in this area where this is actually at the floor of mouth. So it's equally useful even in the oral cavity areas. And so this is the other video of showing how we assess the hypopharynx. So you have to go slow, and if you can give the patient some sedation to help them to relax a bit. But so these are different areas that we should pay attention to when we're assessing the hypopharyngeal area. So you can see that this patient indeed has an early, cancer in the right piriform fossa, extending through the arytenoid all the way upwards near the epiglottis. So these kind of cancers are the target when we have to check for synchronous lesions, etc. So this patient indeed had a multiple abnormality, even beyond in the esophagus. You can already see the dysplastic area in the 6 o'clock region of the esophagus. So this is an important message. So that's why we emphasize it's always important to screen also the pharynx, because both have the same risk factors and pathogenesis. And with MBI, it's actually much easier to find these cancers. So next is differentiation of cancers. So how do we characterize from malignant from benign lesions, predict the depth of invasion, and finally delineate the lateral margins of the lesion? These are very important because this will affect how you select the right treatment for the patient after it's been diagnosed as a cancer. If it's an early cancer of a small size, usually easily endoscopic treatment. Sometimes you encounter very long lesions that are circumferential, then you need to think of whether endoscopic treatment is appropriate or whether you have to think of alternative treatment plans. So generally speaking, we diagnose them based on the morphological appearance, magnified endoscopy appearance, and glucose iodine appearance. So just a very general rule, usually for macroscopic type, if they are Paris type 2, type 1, 01, or type 03, these are mostly locally advanced cancer beyond treatment for endoscopic resection. But if they are in 0 type 2, then most of these lesions or more of these lesions will be amenable for endoscopic treatment. And so more importantly, I think we always use MBI with magnified images, trying to look at the morphology. So as I mentioned, brownish color change, and also the morphology of the IPCL, which can be broadly categorized with different classification methods. So indeed, initially, So as I mentioned, the increasing changes of disruption of the IPCL represent increasing depth of invasion of these cancers, and therefore the first classification was indeed proposed by Professor Inoue, trying to classify different morphology and divide them into different predicted depth of invasion, and thus providing a guide for treatment. But this is rather complex and a little bit difficult to remember because it's from type 1 to type 5, and 5 has also 5, 1, 2, 3, and 5N. So this is a modified and updated classification, also proposed by the Japanese Esophageal Society, that combines simplified the classification by Professor Noe and also Professor Abrima. So what we look at first is the IPCL morphology. So if there is absence of any brownish discoloration, they generally belong to the type A of vessels. But once you have B1, B2 or B3 vessels, these vessels are actually already become neoplastic. So they possess all the factors or the changes that I mentioned. But B1 vessels will still retain a loop-like appearance, while B2 vessels will be non-loop-like, and B3 vessels will be thick green vessels. So they will be 3 times bigger than the B2 vessels. At the same time, you can also look at avascular areas. So occasionally you would see areas that has no vessels at all, and they appear roundish in appearance. So these avascular areas, if they are small, medium, or large in size, also represents the corresponds to different depth of invasion, and you can actually predict the depth of invasion into M1, M2, M3 to SM1 and SM2 plus. So this is very useful classification. Some examples showing B1 vessels. You can see actually the background brownish discoloration and all the different morphologies of this IPCL obviously abnormal, but they still remain a loop-like appearance. While B2 vessels, they already loses the loop-like appearance and appear like long elongated vessels, but they are not too dilated. But this will be a submucosal invasive cancer where B3 vessels is seen. So these are examples of small AVAs, medium AVAs, and very large AVAs also corresponding to depth of invasion. So with these kind of investigation, indeed, you can see that the magnified MBI has a very high specificity and indeed also a sensitivity in terms of the staging depth of invasion prediction, and it's more or less equivalent to stroke-based EOS appearance. And this is a very interesting study presented previously, also from Japan, trying to compare the ability of MBI versus the ability of EOS in addition to MBI in predicting the depth of invasion and whether this would change the ultimate treatment algorithm. So interestingly, what it found was that if you use the EOS, you will have a 6.6% of increase in overdiagnosis. And you also have a 4.5% of underdiagnosis. So at the end, the conclusion from this study is that it seems that the routine use of EOS should not be recommended because it will have a certain degree of misdiagnosis and may not affect actually the outcome or the choice of treatment, or you may actually choose the wrong type of treatment based on your EOS findings. So finally, glucose iodine, I think it's most useful for determining the lateral margin because occasionally the margin is less easy to discern with the MBI, and with that you can actually use the glucose iodine and it will depict it very nicely. And also the glucose iodine, with glucose iodine you do not need magnification, it shows you very well. So you can actually do this and then do the marking for endoscopic resection quite easily. Mind you that with glucose iodine, if you use a wrong concentration, you may lead to a significant stimulation and chemical esophagitis to the patient, and so this is something we should be aware of. So finally, just a very short case sharing. This was done just 1 week ago. So a patient was referred to me for ESD. So young patient, history of tongue cancer. But then it was just mentioned that there was a lesion it was done elsewhere, and there was a lesion at 20 centimeters, a patch of irregular mucosa, and biopsy was moderate to severe dysplasia, and then he was referred for me for ESD. And if you look at the lesion, the esophagus, this is what I saw. So indeed, I believe there is some degree of misdiagnosis. And I think after the lecture, all of you will be able to appreciate that indeed there is not only one lesion at 20 cm. That was the OGJ, and the lesion actually spanned over the entire esophagus, involving multiple areas of the esophagus. And you can see all these abnormal IPCL and brownish discoloration. Some actually already, you can also already see B2 vessels. This is maybe a B1 vessels. and some here there's a bit of bleeding, so difficult to see, but you can see the extent. And now there's some B3 vessels here as well, and again, obvious B2 vessels, non-loop-like vessels in this area. And when I pull up, well, actually, I saw these when I insert the scope, but just use this video to illustrate when I pull back. And now you see this is an ectopic gastric mucosa, or the inlet patch. This is actually the column epithelium, but opposite to this, you can see another lesion here. So this is already in the cervical esophagus, just beneath the UES. And if you use a magnified scope or just a near focus scope, you can see abnormal vessels, brownish discoloration, and non-loop-like vessels here. Okay, so this is actually another cancer. So you can see these cancers. So it's very well illustrated with MBI, and with different morphology, you can also predict his underlying histology and the final diagnosis, and see all these areas are actually cancers. So at the end of the day, I couldn't do any curative treatment for him, for her. So what I only did was I did ESD for the most proximal lesions, because those look early and it may save margin for a subsequent esophagectomy and hopefully preserving the larynx for the patient, preventing the need for laryngectomy. And indeed, this lesion came back to be a squamous cell carcinoma invading to muscularis mucosae. So this is an M3 cancer, so corresponding to the initial assessment of the IPCL of B2 vessels. And so these are actually important message that we always need to screen properly and assess properly with our endoscopy. And with good techniques and some patience, actually, I think we can all do better in terms of diagnosing these early cancers. So thank you so much. Thank you, Honchi, for the concise lecture. The basic is not really basic, and I'm sure we have a lot of questions on the board, but we'll leave it at the end of the section. So our next speaker, Professor Sano. So it's an honor to have Professor Sano here. I think everyone knows Professor Sano well. He's the professor of Kansai University, Medical University, and he's he's the chairman of the Anbiig group, and also one of the world leaders in the diagnostic and therapeutic colonoscopy. So without further ado, so we like to so Professor Sano will give us a lecture on the IEE on colorectal lesions. Thank you, kind introduction. So I'm going to talk back to the basics and diagnostic and the characterization of colorectal lump. It's okay. Right. So this is agenda. I'm going to talk the nice and Janet classification, and then so useful as Janet and regarding to side lesions as well. And as you know, there are two main laws during colonoscopy for the characterization. I think as though the most characterization during colonoscopy is between the diagnosed hyperplastic or adenomatous neoplastic lesion. I think maybe more than 95% diagnosis is neoplasia or non-neoplasia. And the other side is to assess the depth of the invasion or the intramucosal cancer and the submucosal invasive cancer. But this low is a little bit low, I think less than 5%, and slightly difficult. For the characterization, I think is this a pointer? Is this one? Okay. Border jet function is very important to remove the surface mucus, and the attachment cap I don't usually use, but
transplanted food or this black food, shorter type black food is very useful to obtain the close view. And the standing solution, I think maybe more than 90%. I think narrowband imaging enough, but sometimes I use angiocarmine dye to highlight the pit pattern or something. And in Japan, only a suspect of the invasive cancer, or I use sometimes staining using a crystal violet. And this is a historical background to establish a nice classification. More than 10 years ago, this is a final consensus. Maybe 2011, 12 years ago, and at that time, many classification were proposed in the worldwide regarding to the colorectal cancer. And this is an international group, and Professor Tanaka and Doug Lex, very famous anesthesist in the US, and Brian Sanders, his UK endoscopist, Terry Ponchon is France, and Louis Innocence is from Stanford University, and he's David Hewitt, one of the member of this Anbiig. He's from Australia. So we got together and discussed the which is adequate classification in the worldwide. So 12 years ago, the worldwide magnified endoscopy is not so acceptable because there's no dual focus endoscopy, and very limited country use magnifying endoscopy. So this is the classification without magnification. So type 1 is the color is the same and lighter background. So this is a pale, and bezels is usually none or isolated. And the surface pattern is a dark and white dot can be seen. And type 2 and this is correlated with a histologically hyper or sex-isolated lesion nowadays. And type 2 means the color is slightly brownish, and the bezels can be seen on the surface, chura or and the surface is can be seen oval, chura, branch-like. This is type 2. And type 3 showing brown and dark brown relative to background, and has depth disrupted and missing bezel on the surface. And the surface is amorphous or absence of the surface pattern. And this is correlated with some causal invasive cancer. But as you know, also at that time, Western country doctors, I think ESD is very uncommon at that time. So we in Japan, the ESD was common at that time, but the other country doctors, they don't perform ESD so much. But it is one issue, because it's nice to include various regions, adenoma, intramucosal cancer, and some mucosal invasive cancer also. So slightly it's a problem for Japanese doctor. So that because we select the endoscopic target lesion into two types because this is nice to divide it into two types in the genet classification, because 2A means bezel is very regular, and the surface also regular, oval or branching type. And this is most likely low-grade intramucosal neoplasia, low-grade adenoma. And 2B means compare these bezels,